Just want to see my.
So.
You're rolling back, I got it, okay.
Expensive.
That
That is university debt. That's a good work there. So you should make a little, like, you know, I do. Your university in there. Well, you're doing gas. Oh, okay, yes, yeah.
Workshop. We have a full house today. As people wander in, feel free to grab chairs from the hallway. It's nice to see lots of folks interested and engaged with today's topic. My name's Tara Jabin Singh, and I will be chairing today's workshop on pretrial mental health services. Just a courtesy reminder that this board workshop is recorded and it's live streamed on Zoom webinar. There will be no votes taken during the workshop. And we'll start with the introduction of commissioners and presenters around the table and then go around the rest of the room. So I am Tara Jabin Singh, Ramsey County Commissioner for District 1.
Mayor Joe McGuire, Commissioner District 2.
Rena Moran, Commissioner, District 4.
Ling Becker, County Manager.
Nadir Abdi, Deputy County Manager, Health and Wellness Service Team.
Sophia Thompson, Social Services Director.
Anna Hewitt, Manager, Social Services.
Krista Newman, Mental Health Supervisor.
Kenya Walker, Deputy Director of Mental Health. Amira Carter, Planning Specialist, Social Services.
Garrison McMurtry, Commissioner of District 3.
Matt Chong, Ramsey County Commissioner, District 6.
Rafael Ortega, District 5.
Florence Barron, I'm here for Chief Work Student. Alex, Chief Financial Officer. Laura Reyes, Deputy County Manager for the Safety and Justice Service Team. Jennifer Work, Director of Government Relations. Julian Hernandez, Aids Commissioner Country.
Veronica Jackson, Race and Health Equity Administrators, Safety and Justice in Region 3. Rachel Holly, Planning Assistant for Safety and Justice.
Richard Stevens, Planning Specialist, Office of Safety and Justice.
Ashley Ryan, Undersheriff of Detention Services.
Angie Gunther, Race and Health Equity Administrator, Visa and Paulson Planning.
Emily Beltman Swenson, Planning Specialist with Social Services. Bailey, Social Service Staffing. Kayla Pick, Planning Specialist with Aging and Disability Services and Insight.
Tim Mulroney, Ramsey County Judge.
John Green, Public Defender's Office.
Robin Ranweiler, and Rule 20 Care Coordinator.
Charles Goff, Adult Support Manager.
Kathy Eilers, I'm the Director of the Human Services Legal Division and the County Attorney's Office.
Jenna Bartel, an attorney in the County Attorney's Office.
Ann Zimmerman, Assistant Ramsey County Attorney in the Commitment Unit.
I'm Tim Carey, I'm a judge, Second District.
Hey, Sandra Adler, the Community Advisory Council Coordinator for Social Services.
Casey Johnson, Medical Member in Social Services.
Jen Hamrick, Policy and Planning.
Amy Welsman, Government Relations.
All righty.
Fantastic. Well, welcome all. Today's presentation highlights Ramsey County's pretrial mental health services with a focus on the supports provided in the Adult Detention Center. Mental health services for those that are justice involved is often overlooked, and in Ramsey County, we have dedicated county resources to care for those that are incarcerated. The goal of today's workshop is to strengthen our understanding of the work, partnerships, and where we're headed next. With that, I'll pass it over to Deputy County Manager Nadir Abdi.
Thank you. Good afternoon, Madam Chair, Commissioners, and County Manager Becker. My name is Nadir Abdi, Deputy County Manager of the Health and Wellness Service Team. It's a pleasure to be with you for the second time today. Before we begin the workshop, I'd like to express how honored and grateful I am for this opportunity to lead this division and county. I appreciate the trust and guidance as we work to remove barriers from our residents and assist them in their journey to self-sufficiency. I briefly introduced myself this morning, so I won't go into it. But here are our presenters today. This afternoon, Director Thompson, Deputy Director Walker, Manager Hewitt, Supervisor Newman, and Planning Specialist Carter. Thanks for having us and join this workshop so that we can share some of the important work with you. So a little bit of background. This afternoon, we are excited to guide you through the essential information regarding the pre-trial mental health service offered in the Adult Detention Center. We will begin with a foundational overview of the sequential intercept model, establishing a clear context of our discussion. Following that, we will deep dive into the critical importance of service delivery and highlight our strong partnership and entrance and enhance our efforts. Next, we will provide an in-depth look at how social services operates within adult detention center and introduce you to our early care coordination program, showcasing its impactful work. We will also hear from our partners in the courts, who will share powerful testimonies from former clients that emphasize the significance of our initiatives. As we progress, we will discuss valuable insight and lesson learned from our experiences, along with the proactive steps that we have taken to address identified gaps. Finally, we will outline our ambitious future goals, illustrating our vision for growth and advancement in this vital area.
All right, Chair Jevon Singh, Commissioners and County Manager Beckler. Today, we come to you with 3 really simple goals. We recognize that there's a lot, this is a really exciting area, and there's a lot to dig into, and we are anticipating a robust discussion, but you can see by our partners in the room, there's a lot happening in this space. So we want you to walk away with 3 things. We want to start by making sure that you have additional knowledge about the supports that are being provided by our team in the pre-adjudicated jail. And so I know you know what that means, but for those who may be watching that don't, these are individuals that are coming into the jail from anywhere from 24 hours to maybe, a few months. And their time is often unknown, right? We don't know how long they're going to be in there. There's an allegation, and they get to stand in front of one of our, maybe one of our judges in the room, to stand for that. But we don't know. And so when they come for our mental health services, we may have a few hours, we may have a few months. And our job is to really provide the best service we can. So we want you to get a better picture of what that looks like today. It's come to my attention that sometimes it's unclear of who's partnering when and where. Before you today, you have our social services team, but all of these people who sit behind us, many of them are our partners, and we cannot do even the small portion of work we do from the mental health side without those partnerships. And so we'll lean into that today as well. And then the last thing we hope that you get from today is to expand your understanding of the early care coordination that we're providing to the individuals through who are pending a competency determination. You have often heard about Rule 20 this and Rule 20 that, and what's happening with our Rule 20 population. We're going to dig into one aspect of support that we're providing through what we're calling early care coordination. We believe that we're bringing forward to you a pretty well-rounded presentation, but keeping in mind, this isn't about all mental health services. It really is a narrow focus on what we're providing within the adult detention center. And I'll say that our partners in community corrections, they oversee the juvenile detention center and the Ramsey County correctional facility. There's a different set of supports and mental health services that are provided there. So our focus today is narrowed intentionally with the adult detention center. With that, I'll pass to Anna.
Chair Jevon Singh and Commissioners, thank you for having us today. So we're going to start talking today, and I'll pull up shortly, the sequential intercept model. Really looking at, as Sophia had mentioned, our different roles and our different parts within that intercept model and the work. So far, you have heard from some of our partners. You've heard about some of the mental health initiatives. You've heard from appropriate response, and you've heard from safety and justice. As Sophia said, we're going to talk really closely about the work that we are doing around mental health in the adult detention center. So here's the sequential intercept model. Hopefully it's something you guys have seen before. I'll give you a little background. So it was developed in about 2000. It's had a couple of different iterations and changes since then. When I look at this intercept model, I really think of all of the different spots that we can impact change for those individuals, those families, and those persons that get involved or that have contact with the justice system. With this, you've heard about crisis, you've heard about ARI, you've heard about intercept 0 and 1, and today we're really focusing on intercepts 2 and 3. The intercept model is a way also that we can partner with the individuals behind us. and say, we have resources here, you have resources here. How can we help the individuals and the people that are involved in this system? And so we're gonna be looking at that first initial detention, making sure that making sure that I'm sharing with you that we are doing assessments, knowing that assessment is really important at this part, that we are providing mental health care, and Krista will speak firsthand about a lot of that work. And then what that person does is they're moving through that first court appearance. We're not gonna talk about specialty courts today, but we are gonna talk about that time during that first incarceration. And then, as Sophia mentioned, we have recently developed and added in a plan for how folks can be moved out of the detention center. And really considering during that time, how do we set individuals up for that return back to community? And setting them up with access to services that they need and access to some of our other partners. So Ramsey County has really looked at this intercept model. Where do we fall? Where do our resources fall? And where are our gaps in this intercept model?
All right, so this slide here really is looking at how we are partnering. And so our residents and or visitors of the Adult Detention Center, they are at the center of the services we provide. We want to ensure that despite the reason for the visit, individuals are treated with respect and dignity. This is in part done by making sure our partnerships remain strong. Partnerships don't just happen. You have to cultivate them. You have to nurture them. And again, some of the individuals in the room, this is work we've been doing along the way, being real intentional about when we meet, how often we're meeting to make sure that those relationships stay strong. So in the Health and Wellness Service team, this is where the Social Services Department sits. We provide the mental health supports to individuals at the ADC. But also within the Health and Wellness Service team is our public health partners who provide the medical oversight to those who are in the Adult Detention Center. While social services and public health work closely together, intimately together rather, with Michelle Dean and her medical team to provide a comprehensive approach to the service delivery. This includes how we leverage our psychiatric medical director, Dr. Ronald Hardrick, who's been with us for over 5 years, to make sure that when someone is in need of that psychiatric care, he's able to help and consult on those matters as well. In conjunction with the medical care, and I believe Dr. Van Franken is still in that role as well. We both share the electronic health record, so you'll hear often about NextGen. That's the electronic health record we use in our clinical team. Both teams are using that to enter data. You'll hear a little later today about the cumbersome nature of where data comes in and how we pull it together a little bit there. And then we partner to ensure that referrals are made in the facility and externally. Just because someone's in the pre-adjudicated jail doesn't mean they're not able to access services. And so some of our community partners are doing that work. I'll hit on that in just a moment. Our safety and justice partners in the facility are critical to the care team. We rely on Under Sheriff Bryant and her team to notify us when there's a need for a mental health assessment or another action. The safety and justice planning team, also in the back, has been critical in how we assess, analyze, and problem solve the current service delivery and the things that need to change. This is ever evolving. You will remember just a few years ago, or some of you will remember a few years ago, we were still just discussing what is Rule 20 and really trying to understand it. Now it's in our conversations weekly. It's no longer a mystery, right? So the conversation has shifted from what is it to how are we going to make sure that we're serving people right and understanding those gaps. Our court partners, also in the room, thank you, have really worked hard to take a leadership role on how we can, again, look at the service delivery differently. There's several meetings that are held with our court partners to talk about those barriers, to talk about how we move through those barriers and what is in our power and control to do differently. And what isn't, and where there are some things that are not in our power, how can we leverage you all as our electeds to maybe help get some of our laws changed or how we operationalize it? What are we able to shift? And then our community partners. There are volunteers, there are service providers who come to the Adult Detention Center every day to provide services to the individuals that are in waiting in the facility. And when that happens, our team is able to partner with them. If you have a loved one who is in the and needs a mental health care, you can reach out, and Trista and her team are accessible. There are organizations who are doing chemical dependency assessments. While mental health is not particularly contracted with them, or we're providing that services, there is that connection. So I say all that to say this, that sometimes we don't do a great job of explaining how those connections are happening, but they are happening.
Ms. Thompson, one of the questions to that then, so chemical dependency assessments, are those done by the mental health, by social services, by public health, or by outside providers?
Those are done by outside providers. There are times where so it's important to remember that when a person is visiting the Adult Detention Center, currently they cannot, their services are not reimbursable through Medicaid. And so any mental health services that they provide, you can't bill their insurance. Oftentimes their insurance is cut off on that 31st day, right? And so chemical health assessments, while they can leverage the behavioral health fund, which is going to be changing in 2026 per a new law that just passed. The county will no longer be responsible for managing that. You can leverage the behavioral health fund to receive payment for that service, but oftentimes many of the mental health services there's no reimbursement.
Commissioner Moran?
So I'm gonna take us back just a little bit to the Rule 20.
Yes.
In the statement you put out, what is it? Rule 20 has been around forever. So what has been the confusion around Rule 20?
Commissioner Moran, thank you for your question. I don't know that it's confusion as much as it is there was a increase in and around the time of the pandemic. There was an explosion of Rule 20 people that were saying, I'm incompetent, questioning their competency. So Rule 20 is on its surface, a questioning of competency. You go through a process to determine, are you competent or are you not competent? And what we saw in our data was that the individuals who were having their competency questioned doubled, tripled in matter of months. The why behind that, I would like to maybe lean on some other experts that can I table that particular part of the question till later and make sure we do jump back into the why?
Okay.
Because there may be some others in the room that may be able to answer that better than myself.
Is that also a part of why we see individuals sitting in ADC because there's not an opportunity to participate in the Rule 20 because of that explosion? And it's just a backlog now, or?
So statutorily, examiners are required to complete the assessment within 30 days now when they're in custody. So we have not seen, at least anecdotally, we have not seen a backlog in getting those completed. I think the judges may be able to speak to whether or not reports have been delayed in being submitted. But no, we haven't had people sitting in custody awaiting an exam for longer than statutorily indicated.
Okay. Thank you.
Thank you for your question.
As part of our commitment to improving behavioral health services across the mental health division, we've taken several strategic steps to address the complex needs of individuals in our adult detention center. We currently have 4 dedicated mental health professionals and practitioners embedded within the facility. In addition, we have contracted psychiatric providers through Advanced Practice Solutions who deliver 12 hours a week of psychiatric care. They're offering psychiatric evaluations and access to medication management. The unique part of our contracted psychiatric providers is that they can continue seeing those individuals once they come back out into the community. So if an individual has built a positive relationship or a rapport with a provider while they're incarcerated, they can continue working with them at our mental health center. The other thing that has already been mentioned is care coordination. We reallocated a position from our adult mental health case management program to the detention center. And this levy-funded role focuses specifically on care coordination and discharge planning to help ensure that there's continuity of care once someone is discharged back into the community.
Commissioner McMurtry?
Thank you, Madam Chair. Can you speak a little bit more to the psychiatric providers piece? Because I'm wondering, is there a process that we have in place to continue assessing, like whether the services that those contractors are providing are meeting our needs? Like, can you walk me through kind of what the process is of selecting a contractor? Because I think often I hear, we go with, the lowest bidder for a number of these things. And like, are we fully vetting and understanding what these providers are doing, and does it align with what we're trying to accomplish as a county?
Commissioner Big Mary, so the psychiatric providers, I am a part of their supervision for our providers at the correctional facilities 1919 and 402. So I'd like to answer your question if that's appropriate. So our providers, we are really lucky to have two providers at our adult detention center that have worked with us for many, many years. One of which has worked, I think, at all three of our facilities. So when you ask, are they meeting our needs? I would say there's a specialty area when it comes to correctional psychiatric care. And it is looking at what do we have for acute care, what do we have for ongoing care, and how do we best meet that need? I would say our two providers that we have now definitely meet that need. They are engaged with our mental health staff, engaged with our nursing staff. As Sophia had mentioned earlier, we do really have this interplay in the facility. And so we get information from nursing, from the staff from the sheriff's office, and from mental health. And we're really working cooperatively together on that. Sophia had also mentioned Dr. Ronald Hardrecht, and he is our director of psychiatry. He has worked in correctional facilities for years. I have not asked him ever his age, nor will I, but I know he's worked in correctional facilities for years. So I think we are truly at an advantage with those individuals that we have in all three of our facilities.
It's great to hear. Thank you.
Another follow-up question to looking at the staffing that we have, to your point, mental health within incarcerated population is complex for a lot of reasons. One, the high acuity level and complex interactions and diagnoses that people who find themselves are in. But then also the fact that it's such a short period of time and it's such a dysregulating kind of environment. I'm just wondering, given all the changes and all the flux, the 0.5 planner, that's a lot of work to kind of, a lot of teams, a lot of people, a lot of moving parts is this working, and is that position working in concert with other planners, like a greater team? It's hard to pull one little slice and know that they're probably a network of people working on this. I'm just wondering, and give a broader picture of that.
Chair Jebinson, great question. Thank you. So yes, Amira is our planner. And we, with Amira's good use of time, we're able to pull data from multiple systems to be able to report out on what and how we're working with this population. I am never going to say no to your suggestion of more positions or more individuals. I will always happily say yes, please, and thank you. Yes. So know that we don't have a lot of folks, and Krista will get in more to the numbers of the actual individuals that we serve, and it's astonishing. And I think with our planner, we can look at data and we can plan ahead, and further on in the presentation, we'll talk too about some of the other creative ways that we have really leaned into, for lack of better words, on how to provide good care and be fiscally responsible.
And Chair Jebinson, the 0.5 planner position is paid for out of temporary funds. And so the department is responsible for, at the time that those funds are no longer available, figuring out how to continue that at this time. I'll just back up and give a little bit more context. I don't know if we were getting there, but at one time, this entire service was contracted out to a community provider. It wasn't until just a few years ago. So we've been building this. Anna, as the justice involved manager, we did not have that. There was some foresight, I think, by the folks who were in place to be able to say, this is an area we have to build up. So what you're seeing, I would say, it feels like bare bones. It was even less bare bones. And so we continue to invest in this area as we understand it and really build up what it needs to be.
And to that point then, you know, giving the few of us here that are new in our roles, the contracts in these initial years of building internally versus having this contracted out, you know, what are the pros and cons that you've seen in that space?
So I will say that none of us were in our roles at the time that it was contracted out. Krista was brought in at the time that it was, and I'm sorry, Madam Chair. Krista was brought in at the time that it was brought in-house. I believe it was an analysis done that I believe others may have access to that speaks to why it was recommended that this service be brought in-house and that we have closer rails on the services we're providing.
Madam Chair, you know, to the point about bare bone service back then to now, and also what I hear from you is that, you know, this has the need for the services has increased, like doubled or tripled since the pandemic too. Are these the numbers that we're currently operating at right now too, since July 2019?
The number, Commissioner Zhang, the number of staff?
Yeah.
That is the number, yes, that is the number of staff we're operating at. And the backfill to that sometimes is our crisis team. So when Krista has a team member that's down, or I think someone's on maternity or paternity leave, then we use crisis very sparingly. It is not a 24/7 operation. It would be nice if we could. For the 12 hours of psychiatry, the team has done some shifting to do what's called chart checks. So when there's not a provider on site, they are able to review charts and do some of that work on off-site. And so the team has been really creative. But yes, again, I think in many of our services, there's always where you could do more with more. But the team does a great job with what they have.
Okay. Sorry, I'm just wondering if this will be considered in future budgets. It just, yeah.
Yes, Commissioner Zhang, yes, yes, and always, like, in my role as the social services director, right, I'm always looking at what are the needs of the entire department. We'll talk a little bit in a minute about how we're leveraging some of the grants and some of the other opportunities. Again, while this position is funded by a limited opportunity, we're always looking at how we use our other grant dollars or levy to shift. As Kenya mentioned, we took a position from our targeted case management team and rotated Robin, who's here, over to early care coordination. That was supposed to be for a year. The emphasis and the work that Krista will talk about in a minute that's been done in that position has been so profound, we left it there. And so within the department, we are able to shift. You may not have seen it come to you in the form of a formal ask. And we do navigate that, like we do triage, like when do we ask, or when do we work with our partners to, again, leverage maybe a resource they have as well.
Okay.
So you may not have seen it in front of you as a formal ask. And if you were to ask Krista, go ahead, Krista, do you need more people?
Yes. Thank you. Exactly. It just left me off and it just didn't sit right that, you know, you've been operating at that capacity since 2019 and you're telling me that the need for services have doubled or tripled.
Yes.
So that was just very concerning.
Understood. Yes, you're right.
Thank you.
And I do just want to highlight some of the work that Robin has been able to do through the early care coordination, the impact that it's had in supporting individuals in their recovery. So Robin, is connecting with clients who, do need mental health support, and she has been able to divert clients, from going to Anoka Metro Regional Treatment Center, back into the community. And that has been a huge impact, and you'll hear later, from some of the families that she has been able to impact. That results in better outcomes for the individual as well as the community. And our goal is really to create a system that is responsive, that's cost effective, that's centered around recovery, so that we're helping people heal in the community.
So I think in speaking about the mental health services provided at the Adult Detention Center, it's really important to consider the environment, which we've talked a little bit about already. But because we're a pre-adjudicated facility, we tend to serve a really wide range of individuals with very unique needs. So we're oftentimes taking in individuals who are experiencing homelessness, who are experiencing chemical abuse, subsequent withdrawal from chemical abuse, and then maybe unmanaged mental health needs. As a result, the acuity in our facility tends to be much higher than that of a post-sentence facility, such as our CCF or a DOC facility. Additionally, the length of time people remain in custody varies pretty significantly, as you heard Sophia talk about. So someone could be in custody for a matter of hours, all the way up to 2 years, depending on the severity of their charge and the details of their case. Because of the unpredictable nature of the facility, we've worked to identify the areas of service need within the Adult Detention Center in collaboration with the Sheriff's Office and Public Health to best meet the needs of the residents and the facility as a whole. On the presentation slide, you'll see an overview of the many supportive services that social services offers within the Adult Detention Center. Over the past 6 years, we've worked to prioritize these services based on safety. Our 3 high priority services include suicide assessments, facility assessments, and crisis stabilization. Research tells us the rates of suicide in pretrial facilities are often double that of those within the community. We recognize that incarceration is a very stressful time for many individuals and can result in impaired decision-making and hopelessness. So intervening quickly is when someone is at risk of self-harm or suicide is an integral component of what we do every day. Ensuring safety of residents' housing within the facility is also a priority for us, and our team conducts regular assessments of individuals identified as potentially vulnerable, and we make recommendations to detention staff on housing needs while they're incarcerated. There is an identified unit within the facility for those with that the mental health team has identified as potentially vulnerable to a general population unit. And these are oftentimes related to mental health symptoms, but sometimes not. Sometimes it's cognitive impairments, sometimes it's side effects from medications. But our team works really hard to monitor those individuals that are identified as vulnerable in the correctional facility.
I have a quick question on that.
Yes, please.
Given the immediacy of having, being able to be in this specialty space, knowing that somebody walks in the door, it's not as if they may be a familiar face, or they may be somebody we're seeing for the first time. There's no way to know like what is current substances that are in their body versus an ongoing acute psychosis versus an acute medical issue that's underlying, that isn't a mental health issue, but is altering because of whatever, right? I mean, if there's any number of things that are happening, and my guess is within like 6 hours, 24 hours, 48 hours, you could be seeing a very different individual throughout the different times, along with staff changeovers and all of these other kinds of things. And I guess my question would be, given you have chemical dependency assessments being done by outside providers, you've got mental health and behavioral health, social services, and then medical being provided by our public health team, you're sharing that same computer file. So I'm just wondering, like, how often is there capacity within that space, or do you really have to triage who can go into those vulnerable beds or those vulnerable areas? And I'm just thinking, in an ideal situation, you would be able to treat people, and we see this in our emergency rooms too, right? At some point, you're saying who's breathing, who's bleeding, when you'd really like to have a much more nuanced conversation. I'm just wondering where are we at in capacity with some of these complexities?
Thank you for your question. Yeah, I think we absolutely need to triage, and we'll talk a little bit about our referral system. But it's hard to describe the collaboration that happens day to day in our facility and the ongoing partnerships that we have with the nurses on the ground, my staff on the ground, and the officers on the ground. And it is not uncommon that someone is being booked into our facility and the officers are calling us or coming back to our office space to say, can you please come out here and try to help us figure out what's going on? And we're standing there with the nurse trying to determine what's happening. So we work incredibly collaboratively day to day to try to ensure safety of our residents. So as previously stated, the acuity within our facility can be quite high, and residents oftentimes are brought to jail when officers have no other places to bring residents, as you're mentioning with hospitals. Social services works tirelessly in partnership with public health and community providers to ensure residents have access to medications and supportive services while in the jail. We work with residents to get them back to baseline to decrease the likelihood of potential risk of harm. In instances where an individual's needs are beyond that of what we can manage in the facility, we do have a partnership with Regions Hospital. Regions Hospital maintains 2 inpatient psychiatric jail beds in their hospital that are jail cells. I think it's important to consider that those 2 beds are available to all metro area correctional facilities, not just us. So they are in high demand. So oftentimes we're pretty thoughtful in the individuals that we are transferring over to Regions Hospital. We try our best to exhaust all of our resources to get someone stabilized prior to having to transfer them over to Regions, just due to their own limited resources.
And what happens? And what happens when you can't do that? Do they sit in ADC and?
That's a good question, Commissioner. So we have, because of good relationship with Regions, oftentimes if they do not have a bed, I typically call their director and we come up with a plan. It's been pretty rare for us that they have been unable to create a bed for us. I think due to solid relationships that we've built. But in the past, we have had people serviced in their emergency department because they have more access to psychiatric providers in their ED than we do in the jail.
Does that mean they sit in the emergency room?
With an officer.
Yeah, with an officer, yes.
Madam Chair, I have a quick question about services at the hospital. Is that service not billable to Medicaid also? So we, Commissioner Jean, we have a contract that covers that service. But you're right, while they are at the hospital, they are still technically in custody, even though they're physically at the hospital, they are still in custody at the jail, so that would not be billable. Okay, and the services that they receive at the hospital then is not reimbursed. Correct. Medicaid. The contract that the county has pays for those services.
It's my
with
understanding.
Regions.
In part,
Okay.
I would say the care is complex and varies based on individual needs. So yes, we have agreements with Regions. We also are paying for a majority of this out of the public health budget.
Thank you, Madam Chair. Just very concerning overall with a lot of the federal issues around Medicaid right now. Commissioner Ortega.
I just want to add that, because I sit on the board of directors of Regions, that I is speaking with the president. We talked about taking the whole board, have Lynn arrange, maybe on a Tuesday, whatever your pleasure is, and take a tour of the mental health facility specifically. And so that's on their radar.
Yes.
Thank you, Madam Chair. Just to clarify for me, do people that are on Medicaid, once they arrive at JDC or at the ADC, they lose their Medicaid? I thought it was when they were incarcerated, they lose it, or what? Remind me how that goes, because I know we were arguing that they should just keep their Medicaid the whole time, whether they're incarcerated or not. Like, we don't want them to lose their Medicaid. We want them to stay on that. So remind me where we're at with that.
Commissioner McGuire, that is a great question. So we have federal statute components that indicate, 1115 is the statute number, or sorry. Yeah, 1115 is the statute number. Got way too many statutes in my head. That indicates the inmate exclusion is what it's referenced as.
Right.
And we had some initial kind of movement and discussion at a federal level. I was thankful enough to be able to be involved with some of those conversations with jails and correctional facilities, pre-sentence facilities across our nation in talking about what does this look like? That has really halted with some of the recent changes.
Yeah, I will just say it was probably one of our top issues that NACO was, I think, lobbying on. I'm sure I was, sure I was in those offices talking about it. It was our big issue. So thank you for reminding me that it didn't go where we wanted it to go, but we're still working on it. Okay, thank you.
Appreciate that.
Yeah, but yeah, thanks. Okay, Commissioner McMurtry.
Thank you, Madam Chair. Do we have a relationship with Fairview? I know that they're opening up their new mental health hospital as well. Is there any collaboration between the county and them?
Commissioner McMurtry, so I would say we have a relationship with all of the hospitals. It varies into what that looks like. When it comes to specifically to Fairview and the new hospital, I was in a meeting today and we're collaborating and connecting about what the next step should be with that particular behavioral health hospital. With regions, the specific contract we have has been a legacy contract that's been in place for quite a while. But we also have a relationship with, Children's and even in Minneapolis, Fairview. And so we're able to leverage those spaces. What the relationship looks like with each is a little different.
I imagine.
Yeah, I can speak a little bit about the Fairview because Sophia had reached out about connecting with them. So a few months back, Judge Carey, myself, Deputy Mayor Tincher, John Choi, we connected with the leadership team at Fairview within the new facility. I know a lot of you have gone on some tours there. So the next step, actually, Judge Carey and I just had a conversation before this meeting. He's due to have a meeting with the person who kind of coordinates that front door for that. And then our plan is to have another meeting with Sophia and myself and then kind of bring them full circle back to the board because we need to kind of figure out what is the viability around how they're set up because capacity wise, I'm not sure they're going to be in a place to be able to be a big support here, but we'd like to push them and encourage them to be, right? And so I think they shared some other community work that they're doing with all of you. So I think there's some coordinating work that we'll do on the front end, but I'd like to kind of lean on all of you to say you would like them to come back and circle back with the whole board based on your individual visits with them. So this would be a good time to confirm that direction from all of you. So, okay. Yeah, that's good. Thank you. Sorry to interrupt that. Yep.
Where are we at? Go ahead.
So beyond the 3 priority referrals that I just talked about, we also do a number of other things. So certainly providing therapeutic interventions, including offering community resource information, developing pro-social coping skills, and then providing short-term solution-focused therapy. Our internal mental health team makes all of the referrals to our contracted psychiatric providers. So we are meeting with those individuals, trying to triage who needs to see psychiatry. 12 hours of psychiatry it's not a ton. And so we have to be pretty thoughtful in who is being referred for psychiatric care and medication management. And then we also have the opportunity to provide mental health training to all new officers that the sheriff's office hires for the jail, as well as doing in-service trainings for their current staff. And then I'll talk further about early care coordination on the slide coming. So our numbers are a lot. So in 2024, I will preface this with I had 3 full-time staff at that point. So we were triaging over 4,000 referrals, which is the average of 368 per month. We receive referrals from several different places. So primarily in-house, we receive referrals from the officers, from medical staff, and then individuals can self-request to meet with us through the kiosk on their living unit. And then additionally, we have partnerships with the courts. So we get a lot of referrals from attorneys. Judge Carey likes to email me on Fridays and send me referrals. So we so we get a number of referrals from our partners as well, including case managers, family members of those who are incarcerated, anyone who can kind of find our phone number, we're getting referrals. So hence the large volume of referrals.
Wow, Commissioner Richard.
Quick question on that number. Are those, the 4,000, are those all new people or are there like repeats in that number as well?
Thank you for the question, Commissioner. It includes both.
Okay.
So that really includes new referrals, follow-up requests to be seen, suicide assessments, crisis calls, you name it. So we also get a pretty wide variety of referrals or requests to be seen. So someone may just request to see us to get one resource or difficulty sleeping, or just want to check in about kind of the adjustment period as they transition into incarceration, all the way to someone is presenting with acute psychosis. So we, again, because of the high volume of referrals, we have learned over the 6 years to really triage referrals and ensure that the people who are demonstrating the highest need are seen most quickly. I think it's pretty amazing that the staff that are at the jail, despite those really high referral numbers, have been able to fall within 7 days of kind of a standard referral, which is within guidelines for NCCHC standards for best practice for mental health care and correctional facilities. And then I think it's important to note that for crisis calls, so for those individuals who are presenting with safety risks, and are not adjusting well, we're seeing them immediately or as immediate as possible. We are intentional in our staffing patterns to have staff on the facility, at the facility 7 days a week for 10 hours a day. We try to be there as much as possible, you know, knowing we can't be there 24 hours a day with our current staffing, but trying to ensure that we're responsive when someone is presenting in crisis.
I just want to interject here and ask a couple of questions about caseloads. I used to run a day treatment program for adolescents, and the ratio of people that you have here to staff blows my mind a little bit. I mean, what are your caseloads for the staff that are there?
So thank you for the question. I think that's a great question, Commissioner. We don't carry typical caseloads because it's such a fluid environment. So I will say we have specific productivity standards. Staff are expected to meet with a minimum of 5 people per day. I will tell you, my staff are overachievers and typically far outpace that. But as a minimum, 5 people per day. So, and it's not traditional therapy, right? We may be at someone's cell door because they're unable to come out of their cell or unwilling to come out of their cell, or it's not safe for them to do so. Oftentimes we're meeting people in the interview rooms on the living units. So they could range from a 10-minute check-in with someone all the way to an hour-long visit to process through some things.
And then I guess, you know, thinking about that, how much are you also relying on some of these contracted staff and volunteers for, again, what you're saying isn't a typical therapeutic load, but as far as like the check-ins and the circle backs and things like that, I mean, is this just on staff or is it, okay?
Yep, this is all our internal mental health staff.
Okay.
Our mental health team also refers to the psychiatric providers, as I talked about. So as you can see, in 2024, our providers were able to complete 211 new evaluations for medication. And unfortunately, due to the high level of acuity in our facility, we do have to triage those referrals pretty significantly. So we are primarily referring for things like psychosis and thought disorders, less so for mood disorders. We do partner or leverage the chart checks that Sophia referenced earlier, with some of our other contracted psychiatric providers who can review maybe records that are outside of the protocol for medical to be able to automatically resume medications when they come in. But we've met with the individual, they're indicating symptoms, and our remote providers are able to review that chart and get medications resumed that otherwise they may not be.
With that too, I know that there has been some new legislation or clarification on rules as far as people come in with their own drugs, and then the idea of whether or not you can continue them and whether or not that's onerous or great, or I mean, I think that when we have legislation that's statewide, it may be prodding and bringing people level set up to places and parts of the state where they're not there, but it also then may impact those established programs in different ways. I'm just curious your thoughts on those new rules and what that will mean for you all with medications.
Commissioner Devon saying, we are at the very beginning of this. Was supposed to be implemented on July 1st. There's certainly an injunction in place, is my understanding, and still kind of feeling out what this is going to look like. To Commissioner Zhang's question, medications administered in the facility are paid for at full price by our public health partners. And that is why we are working really closely with them, and we'll talk on some of those partnerships that we have working with public health to ensure that medications and in particular injectables for antipsychotics can be continued for individuals.
Keep us posted on how that pans out.
Commissioners, I do believe there are some dollars that were put into the system that counties can leverage, and so that just recently passed, so we'll be looking at how to apply for what, if I recall, it wasn't a lot, but we'll be looking at how we leverage those dollars as well to pay for stability, because what we know is that if we can get someone on their medication and they can remain, then they won't necessarily have to leave and go to maybe another point of care that's not where they need to be. Not that, I mean, sometimes they do need to remain at the adult detention center, but we don't want to transition people out of the adult detention center to the state hospital, for example, when they really don't need to be there, if we can get them stabilized in the adult detention center.
Thank you. So amidst the COVID pandemic, we talked about this a little earlier, incompetency determinations and subsequent wait lists for state operated facilities became pretty inordinate. At times, the wait to get into a DCT placement or a direct care and treatment placement took 2 to 3 months. So people were stuck in jail for very long periods of time during that time period. It became apparent that alternatives needed to be considered more quickly than legislation would be able to implement the Forensic Navigator program, at which time we developed the Early Care Coordination Program in Ramsey County. The intent of this program was to help identify those in custody who are pending competency evaluations that could potentially be served in community-based settings rather than hospital setting. The care coordinator does this by reviewing a daily report of competency evaluations ordered in Ramsey County, which is a report we get in partnership from the courts, identifying those that are currently in custody, and then meeting with the resident to determine potential treatment needs. In many cases, the care coordinator partners with the mental health team for medication and stabilization needs. Once the resident is assessed as being stable enough for community placement, the care coordinator, or Robin, works with community placements such as IRTS facilities, group homes, and CD treatments to complete referrals and files a bridge plan into the individual's criminal court file. Once that bridge plan is filed, that is reviewed by our criminal court partners, including the county attorney's office, the public defender's office, and the judge, to determine whether or not they will issue a conditional release. When we are filing those bridge plans, they are outlining expectations of the individual for once they release from custody, and it typically includes where they're going to live, what appointments they're going to attend, what services they're going to have in place to help them be supportive in the community. If approved for the conditional release, Robin will facilitate the release from custody with jail staff and transportation, as well as our medical staff, to ensure that residents are released with necessary medications and to a warm handoff.
Oh, before you go to the next slide, sorry, commissioners. So the other piece I'd like to add here is that when I think about our case management staff and that reporting structure, it's important to remember that as we're trying to do innovative shifting in how we're approaching, sometimes it takes a little longer for the other parts of the system. So for instance, with mental health case management, their role is to support with the mental health piece, not necessarily report back if a person is not on that civil commitment. And so we're still trying to work with our some of our vendors, if you will, or our case management agencies to recognize that their role isn't to report back, but we're asking them to shift and maybe do something different. And that takes a little longer to work through. And so I guess my example here is that while one part of the system is evolving and changing, it takes a little bit of time for those other entities and partners to maybe see their work differently, or they want to stay. Like, this is our role, we want to stay in this role. And when that happens, we have to find other folks like Robin who can kind of weave in and out of the traditional role.
Well, and to that point then, I guess, as we are trying to divert folks into more appropriate for their treatment plan, if for some reason there's a loop, there's issues with looping back on reporting or making sure this is actually working, or if this has been successful, what happens if it isn't successful? If somebody gets a chance to go in and for all sorts of reasons with these high acuities, that even in best case scenarios, even somebody who wasn't part of incarceration may also not be successful because that's just how it's hard to treat things that are hard to treat. How do we loop that back to make sure that we're dealing not only with what's right for that individual, what's right for public safety?
Mhm. That's a great question, Chair. Thank you. I think that's where our partnership with the court partners comes in. And deferring to them, our area of expertise is not public safety, and that's where we lean on the judges and the county attorneys and the public defenders to really look at what the public safety risk is, and making appropriate determinations from that end of things. Our job is to identify potential treatment needs. And if they are released to that plan, that's great, but we do that very intentionally with partnership with the court partners who are experts in that area.
Commissioner McMyer?
Oh.
No, go ahead.
I'm going, okay.
Sorry.
It's a combination of the two of us. I think it's good.
The mix.
My question was similar on those lines, because I'm looking at this saying, okay, so we release them to a more appropriate setting, but they are still in our correction system. I mean, they're still, I don't know if they're wait a second, they're in custody. So I'm trying to figure out if they're in pre-adjudication or post, and they need to still be served. So are there very many places in the community that can happen? I just didn't know we had places like that. And so I'm glad that there's community-based places where they can be, and that's why you have to work with the courts and everything. Wow. So, and do we have enough, do we have very much room in those places, or is that what you always have to figure out? Are we at capacity, or how are we doing it? We can always use more, I'm sure, but yeah, no.
And we
Oh.
have leveraged some grant funding to work with housing providers to train them to work with this population. We've also been able to create kind of a housing list, so those ones that do feel more comfortable working with justice involved individuals are, stating when they have openings. But even that is still, we're still working to continue to build up their skill set and build capacity.
Commissioner, I'd also say that there's a desire to continue to have facilities that are locked or that are hard to get out of. And so a few years ago, maybe last year or 2 years ago, there was some legislation passed for a locked IRTS facility.
Okay.
And to my knowledge, there weren't any providers that applied for that opportunity. And so it was put out there, but how we bring the community, the provider community around to wanting to do it in a safe way and making sure that their financial incentives are there, right? So if we're gonna add this level of care, how do we make sure that I'm not being paid the same rate as if I didn't have that secure or locked? And so this is that continual balance of a person's right to choose and their own self-determination, and when we decide for them. And it's a moving target. It truly is, outside of, especially if they're not on civil commitment. There's when a person is under civil commitment, we have more stronghold. It's when the individual is not that we have to really negotiate and barter, if you will. And I may be in a good space today and tomorrow I'm in another. So our laws don't really allow for that wiggle room, and we have to figure out some ways to work within that. And I think that is a challenge in front of all of us, is understanding the gap, which we have a meeting called our Rule 20 gap, understanding the gap, and within that gap, where are we gonna work to plug or fill the holes? That is the challenge before us.
Just, thank you for all this. This is great information. So I'm assuming that these places in community, that they're community is it next to community or these are places that are there in community sort of?
These are homes next
These
to
are
your
homes
house.
next to your house, so if they're just as involved, there's gotta be security then at that home, and do people really necessarily know, or there doesn't necessarily have to be security at these places?
The licensure,
Okay.
Commissioner McGuire, the licensure for an IRTS facility or a group home does not require that level of security. That's the desire, I think, or that's where we're seeing the gap. There needs to be
Yeah.
a place for that population as well, and we haven't been able to lean in there yet.
Because obviously you're taking into account safety of the community as well, you know, you're not putting people in those homes that might be a danger to themselves or the community necessarily.
And that's the partnership, right? So when
Right.
Robin is working with the team, if you will, to determine, is this person the right fit? Is this the right situation? Who's gonna be helping monitor while this person remains in the community?
Director, can you define what an IRTS is for folks who might not?
Yes, I apologize. Thank you, Madam Chair. A nurse facility is an intensive residential treatment services, IRTS. And it's short term, ideally 90 days. It can be a little longer. It is medically reimbursable. And it's where it's kind of a step down. If you think about hospital, state hospital, an IRTS would be your next level of care. And it's where someone can go and stay for 90 days to receive treatment, supports, and kind of stabilization before they go down to the next level of care, which might be, to their own home, or unfortunately, sometimes our IRTS facilities discharge to shelter because of the standard of they should really only be there for 90 days unless they're reassessed to stay longer.
And I think the only thing that I would add to that is the consideration of, for these individuals who are incompetent, they are unable to move forward in their criminal case. That case is suspended. And so for us, it's really, as social services, trying to fill that gap of, so now what? If not Anoka Metro, if they don't require that hospital level of care, and even if they do go there, they're still coming out into the community at some point. Right? And ideally, individuals are restoring to competency at some point, but for some of our population, they don't. And restoring to competency is a very finicky process. So I think the intent of this program is really, if not AMRTC or Anoka Metro, then what? And what are our options, and how can we serve these individuals without just releasing them to nothing? And having them go out into the world with no supportive services and nowhere to go.
And just one last, Anoka, AMTC. It may or may not be for everybody, and it's really expensive too, right? I mean, it's really pricey, so if you can find alternates that work better for people, it might be even less resources.
Commissioner Murchie?
Can you speak a little bit more about the restorative competency? Because how many folks are able to achieve that? Like, what does it look like? And because it really feels like there's a gap in that group of folks who we are working with, and those who aren't able to restore to competency, how likely are they just to re-enter the system again? So can you kind of speak a little bit more to that? Is that something that's achievable, and what does it look like?
Yeah, thank you for your question, Commissioner. I would like to lean on our court partners. I think this is where that data becomes so complex. Because we are pulling it from so many different areas, and I think we'll talk about that a little further soon. But we are pulling from many, many systems, right? And so I think we'd like to come back probably with information.
Well, if I can phone a friend, we can get someone to bring in. I just want to make sure, I don't know if we're at 3 o'clock, till 3 o'clock or not, but we have about 6 more slides and a 5-minute video. But do one of our judges want to speak to that?
So.
Can you come up to the mic though? Can they come up a little bit closer?
You can sit right there.
You go first. No.
Well,
Hi,
Hi.
I'm Tim Carey, judge in second district. So the question is, how do we get people restored to competency, and what does that look like? The problem is, so if we have, there are a few different problems for the in-custody medication assessments. The work that's happening is great. If we could like quadruple that, and no joke, but if we could have someone who works there like full-time, who could prescribe medications What we know is that if people's diagnoses require medications or respond well to medications, the longer they stay decompensated or symptomatic of that mental illness, the lower their baseline becomes. So we can only get them, the level of wellness we can get drops the longer they're decompensated. So if we could expedite access to those medication assessments, that would help. And getting them into an appropriate treatment setting for those medications to have a maximum benefit would help. One of the great realities of Krista and Robin working together is that we do get people out to places like IRDS facilities more expeditiously. But if they get out and they're not willing to stay there, they sometimes get placed and walk right out the back door. So we have the double whammy of the clinical care needs not being met, and community safety is then in the balance as well, depending on how they're doing at the time. So that's to take it back to the locked treatment options within the community. Having something like that would be an incredible shift in our ability to maintain community safety and stop the expenses that we are spending on constant rearrest, reassess with crisis, another felony first appearance calendar that's staffed by a judge and 2 lawyers and some risk assessors, and 3 hots and a cot in jail, and then all of the other services. So, do you want to add to that?
No, I agree with everything you said.
And I just want to be cognizant to all of us, we've got some meaty slides left and our time is running slim.
Mhm.
So, good, that's all. All right, Commissioner John.
I want to keep us on this, on the timing about like just the amount of time it takes. How are we doing for, when a competency assessment is ordered? Like, how long is that, taking us? And then the other question was, when Judge Terry mentioned about that, if we could just expedite like just the prescription, or if that we could do that in-house, like that would go a long ways. Like, what is the barrier to that at the moment?
Commissioner Zhang, so one of the barriers is prescriber time. And in about 4 slides of him, we talk about a grant that we are able to increase time, but as Judge Carey had noted, having a prescriber available with more time is always important also to consider. I think part of your other question was length of time from assessment for Rule 20. And Krista had spoken about that, I think earlier, stating it's approximately 30 days for in custody, and that falls within statutory guidelines.
Okay.
So from time of assessment being ordered, assessment being completed, and returning to court.
You know, one thing that I'm just thinking about for us as a board too is about even considering or placing a goal for ourselves, right? Like, even though that's the statutory like timeline, like what about for us? Like, if we can get it done sooner, and what I hear is that the services that are offered outside of that gets reimbursed, that means that we are cutting costs on our end, right? Like, the longer that we hold folks that are in like, we can't get reimbursed for those services. But if our goal of shortening that time and allowing for folks to, you know, receive these other outside services, those are reimbursable services, right?
Yes, and Commissioner Jones.
Mhm.
So knowing that competency assessments or the Rule 20 assessments, as they can also be referred to as, those are ones that are covered by our court partners. We are not in social services completing those assessments, and those are not reimbursable. Because it is a assessment looking at competency for the criminal justice system and setting, which differs very significantly in some of the factors from a diagnostic assessment or a comprehensive assessment or chemical dependency assessment, which is also called a comprehensive assessment. So looking at different factors and different uses for that assessment.
And if I can just add, so the individuals who, the pool of individuals that are able to complete that, we've been looking at over the past few years of, is there a way we can expand the pool? And my understanding is the pool is pretty limited in the providers that we have. that have that specialty. So this is a statewide concern when it comes to who is able to complete that comprehensive assessment. And I just wanted to draw the line that it is not the mental health staff that are doing that. It is a contract that I believe our court partners have with the individuals that are able to, and I believe it's what, 3 people? I mean, it's
Juvenile, we have 3, for adult, we utilize Hennepin.
We have several different
Contracted.
independent contractors. Is that fair?
okay.
Okay, and just a quick follow, if they're found not competent, then are they released from our care?
That depends.
Okay.
On the charge. If it's a misdemeanor, yes, that charge is dismissed. If it's a targeted misdemeanor, there's all sorts of,
It's nuanced.
yes, very
Yeah,
nuanced.
very nice.
Okay,
But ideally, yes, we can't hold them in custody forever once they're incompetent. So yes.
okay. Thank you.
And I would also add to your question, Commissioner Jean, the unintended consequence of shortening that turnaround time for a competency evaluation. One of the unintended consequences I would worry about is for individuals presenting with substance use, and how long some of those substances can remain in your system. So for individuals who are withdrawing for a number of weeks, if they complete their competency evaluation while still experiencing some of that withdrawal, I worry that the assessor could opine incompetence based on that, whereas another week they may have cleared and present very differently. So
Yeah, thank
it's
you.
definitely pros and cons.
I know we're moving on home.
Yeah, I was gonna say, I had
Move on.
tons of questions, but I do think we do need to
Yeah.
keep moving on.
I will skip this one. Go to the next one. Go ahead. So you have a slide on the data, given the time and the information's there. We're gonna skip the data right now unless you really want us to. We do want to get to the next slide here.
So you've heard from our court partners today, Judge Carey, and I think Judge Maureen just stepped out, but they have been really close partners with us in developing some of the innovative work, specifically in our care coordination program. So as they both stated in their introductions, there are Ramsey County District judges, and they preside over the Rule 20 calendar, so the behavioral health unit of the courts. From time to time, they also do some civil commitment court work as well. So I had the opportunity, I work with them often, but got the pleasure of sitting down with them for about a half hour a couple months ago to do this interview with them. And this interview really took the time to ask some questions about service delivery, about some of the challenges that, they are seeing on their end of our partnership, and some of the goals that they have for the work and as we evolve and become more innovative in what we're to do. So I have about a 5-minute excerpt of the interview for you today. I'm just gonna make a note. It kind of starts right as Judge Carey's in the middle of a sentence. But just to kind of give you a background of the question that I asked to them prior to him starting was about our partnerships across the court system, our county attorneys, the public defenders, our mental health team, and specifically kind of in regard to care coordination and how that works. So. So I just want to take a moment to thank Judge Carey and Judge Mulrooney for taking the time to sit down and allowing us to play this excerpt. I know if they had it their way, they'd love to come and speak with you all as well. Yeah, but to kind of emphasize the note that Judge Mulrooney left us on, it really centered us back in resident care and resident experience. So I'm just gonna outline kind of where some of these quotes come from and allow you all some time on your own to reflect on them. But on the left-hand side, of the slide in the bolded text are testimonies from clients that Robin has worked with that have bridged out of the jail and have been put into community placement through the care coordination program. On the right-hand side was an unprompted write-in to Krista from a guardian of an individual that Robin worked with and kind of the success of the program. So I invite y'all to read those on a time outside of this to give us some time to move them to our next place.
Man, I can talk fast. Hopefully you guys can all follow. So we've talked a lot about what we've learned in this. We haven't talked a lot about what some of the asks are, where some of the things are not going as well as we would prefer. As Krista had mentioned, we do have referrals that can come in from clients. So they have kiosks within the facility that they can request services. We would absolutely be elated to be able to respond to those requests as quickly as possible. We would love to ideally offer more diagnostic assessments, as we had talked about earlier, and more of that psychiatric time, and looking towards, as our state is moving towards more standardized release planning, looking at how we can engage in some of that also, knowing that this is a pre-sentence facility and we don't always know when someone is going to be leaving. We want to also make sure that we are decreasing the amount of barriers to release planning as much as possible for those individuals. And the next slide, we'll talk some about grants, but we've been trying to really be thoughtful about how do we lean in and do this work with our partners, knowing that we are together as one team with our courts, with the sheriff's department, with our other partners in safety and justice, with corrections, and with our nursing and medical folks to really care, as the judges cited in that previous slide, for those individuals. The facility considerations are, jail's a hard place to be. It is a really hard spot to be in, and Krista spoke about some of the cells, and I think we'd always love to be able to improve that. We have been able to decrease our folks that are entering into other facilities, and we want to ensure that we can help people get back to that spot where they need to be at while they're incarcerated. We have some other pending things that are coming up. Commissioner Jevon Singh, you had mentioned some of the changes regarding medications for those that are incarcerated. We also have some pending changes with regards to 2911, which is our licensing as a correctional facility. And today we've talked a lot about statute 611, which is changes that happened last year. And as Judge Carey had mentioned, how do we get more of those assessment pieces done for individuals for psychiatric care, and with these changes within the statute?
And I just want to ask too, just to highlight, it seems to me in some of this data that 10% of the ADC population is identified as needing some of these things. And so this not only impacts these individuals, but it impacts the staff that's general population and those behaviors and what that extra pull is on general staff within the jails that aren't part of the mental health behavioral health system as well. And so one of the things I was thinking about as you had these kind of additional considerations is the new iPads that are going in for communication systems. I mean, is that a way to leverage some of the lighter touch mental health issues that may be going on, or peer-to-peer support, or just to be able to amplify our other partners outside of the staff that we have here?
Chair Jevon, oh, go ahead.
You go ahead. Chair Jevon Singh. We're super excited about the iPads. I think, yes, absolutely, that will offer a lot more access for residents in the facility to programming, to CBT interventions, to all sorts of different communications. And boredom is a very real thing in correctional facilities. So I think even just having access to different stimuli on an iPad is going to be hugely impactful in the correctional facility. Very excited about it.
So this is the slide I'm really excited to talk with, one of the slides I'm really excited to talk with you all about. So what have we done with the resources that we have access to? We have a great training ground for interns. We've been able to have bachelor's level interns, master's level interns. We've also worked with the University of Minnesota in their Carlson School. That's how Amira came to us. was we looked at partnering with our community and saying, how can we do some of this work better? How can we dig in deeper? And how can we look at it from multiple perspectives, not just those of us that are doing the direct practice work? We have been able to pay our interns also in Ramsey County. When we talk about individuals living with really severe persistent mental illness and chemical dependency, we can train really good providers by giving them exposure to how to work with people while they are not doing well in facilities and out in the community. We had MET, which is a program that is for individuals over 55. I can't believe I have to say they're older individuals over the age of 55 coming back into the workforce. We've been able to work with that individual. She's currently not able to work with us due to some of the federal funding, but we've been able to work with, Jen is her name, and she's been able to come in and help us with some of our records and administrative needs. It's really truly been a blessing in our area. We have been able to do those chart checks that folks have talked about previously, been able to do trainings, and we have things in place for neuroleptical treatment orders in the facility, which is a forced order that we can have for individuals that are really suffering and quite ill. We have been working to expedite access to other services while they're there, and we also have grants. So Amira and several of us wrote a grant and we got it for DHS. In that grant, we put in $100,000 for our partners in public health to help pay for medications. We put in training for our providers. We truly see this as work that we are doing across our service areas with our partners. And we work, Chair Jevonsing, you had asked about time for Amira as a planner. We work really closely with Safety and Justice. We have Rich and Rachel in the back here. We work really closely with them also on how are we providing care? How are we training each other? How are we learning about each of the intricacies in our area? Kenya also mentioned a partnership with training landlords. What a great opportunity to have a whole list of landlords that are willing and able and trained in how to work with individuals that are suffering with mental health concerns and saying, yes, I want to. In your community, we want you back in the community. We want to engage with you and we want to help you to have a livable space that's your own. I think the innovation stuff that we have been able to do across our area has really been huge. We've also had, and we've talked just very little bit about our breast competency restoration program. We've worked with some of our partners ahead of what the state has been able to put in place in an effort to really offer care as quickly as possible. And know that the state organizing all of the other pieces that go along with this takes a while, but we could do some more quick and nimble movement.
So kind of going back to Anna's comment about grants and the grant that we were recently awarded that we were in front of you all to have accepted a few weeks ago. This area is supported by levy funds, right? It's not a revenue generating area of the county. And we want to be good stewards of taxpayer dollars. We want to maximize what we're able to do to serve our community members that come into the adult detention center seeking and having mental health concerns. So to do this and kind of talking through some of the grants we actively use. So the state funded adult mental health initiative really helps us push more community-based programming. So going back to that competency restoration program that we have in the community, that helps fund that. The state allocated innovation grant helps fund a bed hold program for some of the work that Robin does to ensure that we have access to spaces in the community for treatment centers outside of the adult detention center. And lastly, that Department of Human Services Early Intervention to Civil Commitment Grant, which is one we were just before you is going to really help enhance our services robustly. So we're adding an additional, we named the early care coordination program Robin because she has been the individual doing the work. So we're adding another Robin and hopefully getting to see what adding another individual to that work looks like in our facility, adding more time to our psychiatric hours. So going from 12 hours a week to 20 hours a week with this grant. As Anna stated, adding dollars in for medication for public health and adding some transportation dollars in to get our clients from the ADC to that treatment center and making sure that they have the best means possible to get there. So in all of that, we're looking for ways to support our partners. We're looking for ways to support our community as well as being good stewards of the dollars that we have.
So as we look ahead, our work in the adult detention center continues to evolve. We're committed to strengthening our collaborations across the county and community, as we try to be more innovative and creative with how we support people, not only while they're incarcerated, but as we're working to help them transition back into the community. We're investing in our staff and programming. We're also trying to expand our data collection efforts because the data will help inform us on what are the needs and where are the gaps in services. We also want to be able to share that data across the various programs within the county. We also want to take a more intentional approach to release planning and discharge planning so that individuals aren't returning back into the correctional facilities. As previously stated, we are mindful that being incarcerated can impact someone's mental health. And so we have been thinking about how do we support individuals while they're there? What is the atmosphere? What does the environment look like? Dakota County recently used some funding to create a trauma center for individuals who are incarcerated. And we are exploring what that looks like, what things we can learn from them and hopefully incorporate in our work as well. We truly thank you all for this opportunity and want to thank our partners for being with us, supporting this work, having some of the challenging conversations to figure out how to best serve residents. It really has helped us navigate and learn what's needed to better support people. Thank you very much.
I just want to thank everybody for this really meaty packet. I will say I apologize to the folks around the table who had additional questions. I have a number of them myself. I would just encourage any of the folks around the table to forward questions to me. I can kind of put this together and make sure that they get to the folks who are doing the workshop. And then also I want to thank the large group of collaborative partners who attended the workshop today. And I'll also extend an invitation, if there is a piece of information that you had hoped that we could have dug into, but we had to kind of push by really fast, or if there's additional information that you think would inform us, feel free to forward that to me too. And I can kind of try to make sure that we don't lose or, don't lose the opportunity to capture some of those thoughts in the room as well. So basically I will say just as a summary that this topic of looking at the mental health social services within our adult detention center, the pre-adjudication, that very specific model still is very complex and deep, and we were able to touch on some of those concerns, some of the innovations that are, some of the challenges, some of the innovations, and some of the things that we'll be looking for in the future. And just to underline the importance of collaborating the braiding of the different sectors and within our Ramsey County system, but also with the courts and our community providers. And so we continue to be interested in this topic. It's so essential to the services that we provide here in Ramsey County. And with that, we are adjourned.
Thank you very much.
Thank you.
Nice job, guys.